Hello, and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We're recording this on July 24th, 2025. I know I've mentioned it a couple times, but Health Affairs released its second Insider Trend Report. The first one was on artificial intelligence in healthcare. This new one is titled The Healthcare Workforce, A Challenge in Sustainability. We also have an exclusive event on 340B for insiders with Saya Nikpe on August 20th. Join us. And today, to discuss the disappearance of public health data and its potential consequences, we have on the program Aaron Carroll, the president and CEO of Academy Health. Dr. Carroll, welcome to the program.
Thanks so much for having me.
So, Dr. Carroll, you wrote in 2017 a book called The Bad Food Bible. You probably have heard of the recent news about adding cane sugar back into Coca-Cola. So, given that you wrote this book, do you have any thoughts on this?
I do. I think the idea that we're going to make soda suddenly healthy by switching from high fructose corn syrup to cane sugar is missing the mark entirely. It's still soda. It's still a sugar-containing beverage, and added sugars are some of the worst things we can do in our diet. In fact, when I wrote the book, it was mostly talking about how things aren't as bad as they seem, but added sugar is one of those where it pretty much is as bad as it seems. So I think we're wasting a fair amount of time on that. Maybe it might taste better. I don't know.
And I would be remiss. So 2017, unfortunately, is 8 years ago. While we're on the subject, is there anything that you may have been studying that you would update?
No, it's funny because I get asked all the time, especially because mostly about alcohol, because they'll come up with new warnings or new but there's very little new research. What happens is they just reanalyze old stuff. We probably could use some good randomized controlled trials, but there just aren't that many done in nutrition. We need to do a much better job in the way we study food.
Fair enough. Good to know. Check out the Bad Food Bible if you haven't already in these last 8 years. So moving forward, you wrote a forefront piece in July 2025 titled When Public Data Disappear, What We Lose and Why It Matters. So to start the conversation on this, I thought it might be helpful to outline what the profession of health researchers look like today. Generally, what does the data look like?
Yeah, I mean, first of all, I should say it's not even just health researchers. It's also practitioners. It's people who are practicing public health. All kinds of people use data, and they use it every day, whether they're studying disease trends or evaluating programs or advising policy. So many people's work depends on data that are timely, accessible, and comparable across regions and populations. And without it, they can't do basic things like identify gaps in care, track the success of interventions, or evaluate whether policy changes are helping or harming people. So we got teaching, mentoring, grant writing, publishing, caring for people, all of that build on the foundation of evidence.
How do they engage with this data regularly?
I mean, sometimes it's literally just going to websites and looking stuff up to see what's going on. Sometimes it's reports that get put out periodically that compare in a variety of ways different populations or different regions of the country. Sometimes they are used in monitoring programs that they might create themselves that upload that data and then track it over time to see if there are changes or things that people should be worried about. You can even imagine in the future that artificial intelligence could be used to monitor in the background all of this data that exists to see if there are connections that can be made and if decisions can be helped by having all of that in a way that can be analyzed. Unfortunately, if you take the data down or you change it without people knowing, that makes all of that much, much more difficult, if not impossible.
And so sitting from where you sit, my colleague Rob Lott had Thomas Dobbs on his podcast, A Health Podyssey, and Thomas kind of painted a harsh, realistic picture of the public health landscape when it comes as a profession. Like sitting where you sit, how does the field of public health research look to you in its current state?
I mean, honestly, it's in a tough spot at the moment. The tools and the evidence that make public health effective are under stress, not just from budget cuts or political disagreements, but from the quiet dismantling of the very infrastructure that researchers and others rely on. So many people are doing critical, life-saving work, but we keep asking them to do it with fewer tools, more bureaucracy, and less clarity about what they can even access. And all of that makes what was already difficult, painstaking, underfunded work much more difficult, if not impossible.
Yeah. Do you get a sense of like how burnout or just leaving the field has been what it's looked like in the past couple of years?
I think in the past couple of years, it's been hard. COVID took a real toll on a lot of people, both working in public health and working in healthcare for that matter, as well as those who do research. A lot more anger, a lot more public attacks. Stuff that we'd never really seen before happening, but. Doing research was never an easy job to begin with. It's very hard to fund. It's very hard to maintain. It's very hard to keep it going. It's very hard to make a difference. And a lot of the changes that have occurred in the last 6 months, again, have only made that much more difficult itself. And as people have seen disruptions in their funding, disruptions in how even universities are treated, changes in how grants can get reviewed or what might happen, a lot of this has removed some of the stability and the assuredness that made the United States special. And that's tragic. And hopefully we'll be able to fix it.
So you mentioned the loss of potential some stability and some anger, especially when you look to some of the actions within the last 6 months. So looking at your article brings up and writes about the potential consequences for losing some of this public health data, which I imagine can contribute to some of that anger or feeling of like a loss of stability. You write that current federal action undermines and creates inefficiencies that amount to de facto data suppression. So I know you cite PRAMS as an example in the article.
That's a great example.
Yeah, if you could give I encourage listeners to read the article, but if you could give an example, that'd be great.
So PRAMS is the Pregnancy Risk Assessment Monitoring System. And it sounds fancy, but really what it's doing is gathering data that are collected in a variety in basically all states across the nation and putting it in one place where you can do comparisons. Using PRAMS, West Virginia was able to see that, hey, wait a minute, our smoking rates amongst pregnant women are much higher than other states. And this is something we should probably focus on. And they did. And they were able to cut smoking in pregnancy from 25% to 10% in just a few years. That's the kind of change that saves lives. And it happens because you could see the data to understand the problem clearly and act on it. But now those data are harder to access. And while they may exist in a state and state and state, researchers can't easily compare them across states because the government's not showing that or hadn't been showing it in a way that everyone can do. What used to be a national resource has become fragmented. And again, that's not just inconvenient, it's dangerous. If you can't see the full picture, you risk missing problems entirely.
Yeah, I don't want to talk about that fractious nature in a little bit, but when you're talking about that, like not getting the full picture entirely, I always have a sense, like I might be an archivist by nature of like trying to have like good data file management for whatever I'm doing. Like, and public health data fits into that quite well, where like, I'm not sure if you can get the implications over time regarding unified, clean data sets. And like, if you alter them in a way or change them slightly, what are the implications of that?
I mean, it has huge implications. Just even small changes to how we gather data in terms of the questions that we ask can have massive implications on what we're following. In fact, we've probably had, some instances in the last decade or so where we even made mistakes and thought there were real changes happening in the world that were just because of changes in how we collected the data or the questions we ask. It's very hard to gather lots of data and put it together in a way that you can use. And fragmented data mean fragmented responses. Researchers have to spend significantly more time trying to get access to the data. They spend way more time cleaning messy files and harmonizing definitions and putting things together in ways that make sense because you may measure something differently over here than we do over there. And this work that used to be done once federally and then shared with everyone now has to be done individually. And over time, that's going to slow down research. That's going to increase costs. It's going to raise the risk of errors. It also means that smaller teams or community organizations that don't really have resources can get shut out altogether if they don't have the skills to do all of that data gathering, cleaning, harmonizing, and everything else. And that's not just inefficient. And it's not just a waste of time and money, it's inequitable.
Your thoughts made me think of a question is that do you have any data horror story yourself that you could share of whether it's someone changing the name on one cell and that changes the whole data set? Have you?
I mean, I just in my own research, I remember on more than one occasion where we were trying to do research on asthma, and we were trying to pull the data from a variety of different electronic medical record systems. And it turned out that in one of them, they had miscoded it as a lower respiratory disease as opposed to an upper respiratory disease. And that meant we got exactly wrong what was going on. And we realized all the work we'd done was 100% wrong. And it was horrifying. And you just realized that with just a small thing like that happening, because we were relying on sort of a couple of different systems and a mistake had been made deep down the line, that you could no longer trust what you were doing. And it's important to do that kind of cleaning and find it, but doing it at a big central level where real experts are doing it once so that everyone can trust that the data that we have are real and actionable and verifiable makes so much of a difference. And the idea that everyone can just do this on their own and we don't need the big federal infrastructure belies a complete misunderstanding of how easy it is to screw this up.
Yeah, my apologies for this question in advance and to put you on the spot. But, from your perspective, how long of a tail might this have? So just changing data can have implications for, data management down the years, and then trying to, counteract what you did a couple of years ago has another, set of change management years. What's your sense of how long this will take to stable out?
I mean, it's hard to say because some things will be easier than others. Some things are just, hey, the states are still doing what they have always been doing. And so if we can just turn it back on at a federal level, they can start submitting the data again and we know exactly how to clean it up and we can probably get everything going again. But some of these data sets rely more on, questions and live things being asked or surveys being done. And disrupting that or making changes to that can have massive implications that we might not see for quite some time. In addition, if we make changes such as removing the expertise on how to clean, put this all together, make it pretty so that everyone can use it, because we start firing people indiscriminately from the government or driving them out of public service into the private sector, that's harder to replace at all because some of these systems have been in place for decades. And there are people who have real experience and probably should train the next generation of people in how to do this. And if we lose all of that, that'd be very, very hard to replace. Further, some of the stuff's reappearing, but we're just not sure it's right because it looks slightly different and we can't figure out, is that intentional or not intentional? There's a certain amount of trust that has to be built over time in how these things get put together. And removing or weakening that amount of trust also has real implications.
Yeah, and also pretty intangible ones in some ways.
Yeah.
Yeah. So you talked about how this might affect the health researcher profession over time, but going back to that trust,
Yep.
how might patients come to view public health data, or even physicians that whether to recommend getting the flu vaccine or something along those lines?
Yeah. I mean, I don't even want to I agree with you. I don't even want to just say if it's just researchers. If researchers and public health officials and clinicians and tons of people can't access the data they need or trust in its completeness, science and health suffer. Everyone is going to become more cautious, less responsive, and more concentrated among those with the resources to navigate the red tape. So the only people who are going to be able to do the work or get benefit are those who really can overcome all of these barriers. And the shifts in who can do research and what gets studied could be massive. Patients may start to see fewer breakthroughs, fewer improvements in care, and certainly less evidence-based policymaking. The public could lose trust, not because the science is wrong, but because the systems that support it are failing.
Well, Dr. Aaron Carroll, as we wrap up, I have a couple more questions, but point listeners to the Forefront article that you wrote. We'll put a link to that in the show notes. In March, Academy Health released a 5-year strategic plan with goals, including to elevate the profession and broaden your reach. And I thought this was interesting. And it's no secret that once relied upon distribution channels 10 years ago are crumbling. So web traffic is going down. Impressions from social media, for the most part, is going down, especially in the digital space. How are you navigating these goals in today's fractious media and political ecosystem?
Well, I mean, we've never been naive about politics in general, ever. But we've always believed that evidence can transcend that. That's why we've remained nonpartisan, even while stepping into this lawsuit. We're not doing it to make a political point. We're doing it to defend the infrastructures or the infrastructure that makes science possible. So at Academy Health, our strategy is to elevate the profession by standing up for the tools researchers need, by finding new ways to communicate their value, and by partnering with allies across a variety of sectors and ideologies to make the case that data matter. You can't improve what you don't measure, and the measurement is super important.
You mentioned a lawsuit. We did not talk about it in this episode yet. So do you want to just mention that real quick? It's in the Forefront article, but
Yeah, the lawsuit is to fight for data that is either mandated or legislatively required to be put back, that it just shouldn't be removed when it should be there. We didn't join this lawsuit lightly. We joined it because the stakes are real. And this isn't about politics. It's about lives. It's about whether researchers, doctors, and policymakers have the information they need to do their jobs. Because when we lose data, we lose the ability to govern effectively and fairly. We lose the chance to save lives. And that's not acceptable. And we at Academy Health are going to keep fighting to make sure we don't lose those tools quietly.
Last question before we go. We're talking about the public health profession. So I was aware of you back in the Twitter days where you were very active on Twitter at the time. I have not on Twitter or X too much these days anymore. But I wanted to ask you, I felt there was a public health community on that. Where are you finding that public health community now if it's not on Twitter?
I think it's trying to rebuild itself on Blue Sky. I see it probably most active on LinkedIn, although I find that, LinkedIn isn't the easiest thing to navigate. But if I'm being totally honest, I think social media is hard to use in this area because I think the biggest problem we have right now is with trust and with addressing complex issues. And social media is not set up to do either of those two things. Trust takes individual interaction over time, repeatedly. It's detail, it's retail, it's convincing people that you're trying to do your best, that you hear them, that you're responding. That's not how we use social media. And complex ideas, everybody's looking for a single tweet or a single TikTok, which gets everyone to agree with what they're saying and gets them to change the behavior in the way that they want. That's not how behavior change works. That's not how change management works. And so I'm not sure where to go to get what everyone is looking for when it comes to social media.
Well, when it comes to social media, yeah.
I think now I'm not tooting your horn here, but it's like, I actually think podcasts are what's going to save us. It's the only format that's really available that allows for this kind of in-depth, detail, long-form discussion where we can address real ideas and talk about them in ways that don't sound like sound bites. You're not going to get that on cable news. You're not going to get that on social media. You're not going to get that in many places. I really do think interviews and discussions like this are what are going to change things.
Well, thank you. I don't know, I'm not going to put words in your mouth, but social media is trash to me. I could talk more and more about that, but Dr. Aaron Carroll, anything else you want to point listeners to while I have you?
No, I mean, I hope that people are following the Academy Health Situation Report. It's something that we've been writing now a couple times a week, just to inform people about what's going on with changes in data and changes in science and changes in research, especially health services and health policy research. Get on the mailing list, stay involved, stay active, get informed, and we all need to work towards a better future.
Dr. Aaron Carroll, thanks again for joining us today on Health Affairs This Week. And if you, the listener, enjoyed this episode, please send it to the model crazy train hobbyist in your life. And we will see you next week.